Okay, so just like last time, I'll explain a few things and then we'll go into the test. Big difference from last time is we're gonna wear the hat because the hair was terrible. It was putrid, awful, anything you want to call it. That's what it was. Anything but good. That's what it was. Professor Donahue, you were probably like, Jesus, what is going on with that? So we're wearing the hat, so everyone's good. So we'll start off with manual muscle testing, and manual muscle testing is just a set of standardized assessments that measure muscle strength and function. Right? We usually grade it 5 out of 5, 4 out of 5, 3 out of 5, and so forth down. So 5 out of 5, the patient can move the limb through a full range of motion against gravity with full resistance. And if they can do that, right, that's normal, right? That's perfect. A 4 out of 5, they can move the limb through a full range of motion against gravity with some resistance, and that would be G or good. 3 out of 5, now we're removing resistance from the picture, right? So they can move the limb through a full range of motion against gravity with no resistance, and that would be F, right? That's fair. 2 out of 5, we've also now removed gravity. So we're moving the limb, and the patient is moving the limb through a full range of motion, not against gravity, with no resistance, and that's P, that's poor, right? Like, hey, come on, let's boost it up. 1 out of 5, right, is going to be T or trace, right? So they're not going to move the limb through a full range of motion, which stinks, but they're not, right? They're going to get it. You might see the muscle flicker, right? You're going to get a trace contraction. And then 0 out of 5, that's not good, right? And you're not going to get any movement at all. So we don't like that, right? And then with manual muscle testing, as we noted last time, and as we've noted several times in class and lab, it's important to assess whenever possible bilaterally. And we always want to start with the uninvolved side because we want to set that base, that foundation, to then compare off of. So we got a few to do today, so let's get started with it. So now we're going to do manual muscle testing, and we're going to start off with elbow extension. So as I talked about earlier, we already have the grades of 5 out of 5, 4 out of 5, and so forth down. So we'll start with our 5 out of 5, which is moving the limb through a full range of motion against gravity with resistance. So what we'll do is we'll stabilize here slightly above the elbow, and then we'll provide resistance down here by the wrist, and they're going to go into extension for me against my resistance. Good. And then we'll put them in like a flexed position, which is the strongest range, and I'm going to do a break test. Don't let me break you out of it. So same hand placement. I'm going to try to break them out of it. Hold, hold, hold. And then we'll assess bilaterally. So same thing. Here, we'll come right over in here. So we're going to, again, stabilize up here above the elbow, provide resistance down here, and you're going to go into extension. Good. And then we'll perform that break test because they can perform that. And then don't let me push you out of it. Hold, hold, hold. And that is manual muscle testing for elbow extension. So now we're going to do shoulder abduction, so moving away from the body. So we're going to stabilize up here at the shoulder, provide resistance down by the wrist for that long lever, and then we're going to move them. We'll do through a full range of motion up to 180 with that scapula assisting. So we'll come here, and we'll go, and you're going to go against my resistance all the way up. And then we would put them in the midpoint because they can do that and perform a break test. So I would say, don't let me break you out of it. Same hand placement, hold, hold, hold. And then we'll assess bilaterally. So same hand placement again, down by the wrist. You're going to go up to 180. Good. Midway with the strongest point. And then don't let me break you out of it. Hold, hold, hold. And so she did that in the break test, so we don't have to go down further with 4, 3, or 2, 1 or 0. So now we're doing manual muscle testing for radial deviation, which is, again, radial side is the thumb side. So she's going to work into the deviation like that against my resistance. So we'll stabilize up here and provide resistance down by the thumb. Good. And then we'll put it in the midway point, and we'll try to break her out of it. So don't let me break you out. Hold, hold, hold. And then we'll assess bilaterally. So same thing. I'll stand, let's get around so you can see. And then we'll go stabilize up at the wrist, provide resistance, radial deviation, and then break test, midway point, hold, hold, hold. All right, so now we're going to be doing the erector spinae manual muscle test. The erector spinae is the spinalis, the longissimus, and the iliocostalis, but we can't really differentiate them, so we're going to test them all at once. So what you're going to have them do is put their hands behind their head, and then almost do a Superman position and raise off, and so they can do that. And then we're going to provide, do a break test, so you're going to go halfway through. You're going to stabilize down the low back, and you're gonna try to break them out up here, and then you're gonna hold. Don't let me break you out of it. All right, hold, hold, hold. And that would be the break test for the erector spinae, where we provided the resistance up between the scapula, or tried to push them out up between the scapula. So now we're going to do the shoulder apprehension test, which is looking for a subluxation of the glenohumeral joint. So you're going to put them up in the functional position. The heel of your hand, if you want to come around here, is going to go right by the lateral border of the scapula with the heel on the posterior aspect of the humerus. And you're going to hold up at the wrist, and you're going to move them into external rotation. And they would be apprehensive. That's hence the name. If something was wrong there. And then we can assess bilaterally to get a comparison. We would always want to start with the uninvolved side first to like set our foundation. So again, that same position, put our heel of our hand on the posterior aspect of the humerus, up at the wrist, move them into that functional external rotation. So something just to add, I was going to say it during the video, but I was like, you know what? Let's try to be more concise and to the point, but I actually think it's important looking back. So as you can see, when I put my heel of my hand on the posterior aspect of the humerus, right, and I push forward, the reason that forward push that I do while I'm externally rotating, if you go look back, is it's important because that's typically, right, the direction of the subluxation we see. So that's why we're recreating that. And again, like we said, hence the name apprehension, they're going to be apprehensive of us doing that, and you know that's a sign that there's a problem. All right, now we're going to do the elbow valgus stress test, and that's assessing laxity of the UCL ligament. So we're going to come here, we're going to do it in closed pack and open pack. So closed pack first is full extension, and we're going to get the capsule. So we'll come here, hand placement by the lateral elbow, and we're going to push medial lateral, looking for that sudden stop, supporting against our side. Then we're going to we'll do open pack, which is the collateral ligaments now, and that same hand placement, looking for that sudden stop. And then we'll assess bilaterally. So we'll do closed pack first, getting the capsule for the sudden stop, and then open pack, getting the collateral ligaments, and get that sudden stop. So now we're going to do the Allen's test, which is looking for arterial obstruction. So first you'll have your patient lay their hand on the table. They're going to clench multiple times just to get the blood pumping. And then they're going to hold and clench. You're going to push on the ulnar and radial arteries, and then they're going to open. And you'll release one. We'll do the ulnar. You can see it filling as we release. And then now we'll assess the radial, which is the thumb side. So same thing. Squeeze, push down. Ooh, I can feel the pulse. And then I'll release. And you can see the blood flow come back. It's not as good as the other one, but it's still returned a little bit. Then we'll assess bilaterally. So same thing, they're gonna pump it up. And then you're gonna squeeze. And we're gonna push radial and ulnar, open. I'll release the radial first. Again, not as well as her ulnar was, but then we'll try it again, we'll assess the ulnar. We're looking for that refill. Here, push, and then we'll lift the ulnar. You can see the color come back. And that's the Allen's test. The next test and the last test is the Faber's test. And I always think F for figure 4. So you're going to put them in the figure 4 position, just like that. And this is for SI joint irritation. So you're going to put your hand down here on the knee, and then up at the SI joint or iliac crest. And you're going to push out and down, and if they had pain, that would be like the irritation. And then we could assess bilaterally. We don't really have it on the side of the table, so she's going to swing around. Same position, figure 4, same hand placement, you're pushing down and out. And that side's much better than the last side. And that's the Faber's test. Okay, so next up we have peripheral nerves, and peripheral nerves are straightforward, right? And that's just, we're assessing the sensory innervation and the motor innervation. So today, here are the peripheral nerves we're going to be working on, right? Musculocutaneous, C5 through C7 nerve root. Radial, C5 through C8 and T1. Superior gluteal, L4, L5, and S1. And then axillary, of course, would be C5 through C6 nerve root. So we got plenty of those to go over, and let's get started. So now we're going to do peripheral nerve testing. So we want to look at the sensory innervation and the motor innervation. So first what we're going to do is we have the musculocutaneous, and this just gives innervation to our elbow flexors. So we'll start by assessing sensory. So I'm going to have you close your eyes to take out that visual input, and we're going to stroke the anterior bicep area. Does that feel the same? And then to assess motor function, we would want to do elbow flexion. So I'm just going to have you go into elbow flexion. Good. And then we'll come over here, assessing bilaterally. Elbow flexion. Good. And that's musculocutaneous. So now for the peripheral nerves, we're going to be doing the radial nerve. So we want to first check it. We're going to do it at the elbow and at the hand. So for the elbow, we would do the sensory on the posterior side because these are our extensors. So you would close your eyes and you shouldn't be able to see it. And I'm just going to stroke. Does this feel the same? Yes. All right, good. Yep. And then now we're going to be doing the motor aspect of that, which is going to be elbow extension. So I'm going to have you go like this for me. So we'll start up here and then go elbow extension. Good. And then like we did with sensory, we want to assess bilaterally. So we'll go here and you're going to go into elbow extension. Good. And then we also want to do it at the hand because it does innervate down in the hand region. And it's going to be, the best place for sensory is you want to do the dorsal aspect of the hand because you'd want to stay away from the distal fence because that would be the median nerve. So what you're going to do is you're going to close your eyes for me. And I'm going to do sensory, same. All right, and then we want to do wrist extension and finger extension. So we'll do wrist extension first. You're just going to put your hand up for me in wrist extension. Good. Assessing bilaterally. Good. And then we're going to do finger extensions. You're going to put your fingers down and then you're going to go up. Okay. And extend. Good. Extension, support at the wrist again. Good. And that would be the radial nerve peripheral test.
And go.
All right, so now we're going to be assessing the superior gluteoperipheral nerve, which innervates the gluteus medius, the gluteus minimus, and the tensor fasciae lata. So for sensory, we want to stroke up by the iliac crest. So we're going to come up here and you're going to close your eyes. She's looking away anyway, so she shouldn't be able to see unless she has eyes in the back of her head. I'm going to stroke. Is this same? All right, and then now we're going to do for the motor function, we're going to have them side lie. And you're going to bend the other knee for stability. And then what we want to do is we want in a neutral position to get the gluteus medius, gluteus minimus, and tensor fasciae lata. So we're going to do hip abduction. So that's in the neutral. Good. And then if we want to do slight flexion for just tensor fasciae lata. Good. And then slight extension for gluteus medius and minimus. Good. And then we want to assess bilaterally as we did with sensory. So we're going to have her flip. Oh, look at that. Now you just move over here. So again, neutral for all three of them. Stabilize at the hip. Hand placed down here. Go. Good. And then slight flexion for tensor fasciae lata. Good. And then for gluteus medius and minimus. Good. And that's peripheral testing for the superior gluteal nerve.
Go.
All right, so now for the last one for the peripheral nerves, we're going to be doing the axillary. And the axillary, it's important to know, only innervates the deltoid and the teres minor. So for our patch that where we're going to assess for sensory, we're going to have you close your eyes. And we're going to stroke on the lateral bicep, same. All right, and then I'm going to have you spin around just so you can see the hand placement. We're going to do shoulder abduction for the motor function. So I'm going to have you go into shoulder abduction for me. Good. And then we'll go right here. Can you see? Oh, my bad. Shannon, doing great. All right, go. Abduction. Go. All right, and that is axillary nerve, peripheral nerve testing. Okay, so continuing on, we're cruising. We're going to do myotomes and dermatomes next. And we just want to make sure we know the difference, right? Or we denote the difference. So myotomes, we're coming off the ventral side of the spinal cord, and that's the motor innervation of a muscle or a group of muscles, right? And then dermatomes, I always like to think DD, and that comes off the dorsal side of the spinal cord, and that's a skin area innervated by a single nerve root. So with the upper extremity, with dermatomes, we're actually going to be assessing our true patches. And then, it's also important to note that in the upper extremity, dermatomes are actually horizontal bands around the trunk. When we assess dermatomes, we want to do light touch, deep touch, pinprick, and then make sure that our patient has their eyes closed, just so we're eliminating any visual cues that could help them out there. So let's go into those.
And go.
All right, so now we're going to be doing myotomes. And myotomes, like we just mentioned in the previous video, come off the ventral side of the spinal cord. And the first one we have is C7, so we're going to be doing elbow extension, wrist flexion. And we're going to assess bilaterally. So first we'll do elbow extensions. I'm going to have you come up here, You're going to go extend, good. And then, and we'll do wrist flexion while we're right at it. Wrist flexion, good. And then assessing bilaterally. Elbow extension, good. And then wrist flexion, good. And that would be C7. All right, so now we have the next one is myotomy C8, so that's going to be finger flexion, thumb extension, and ulnar deviation. So again, we're going to assess bilateral, but we'll just do all the movements on one side first. So first we'll do finger flexion, I said, so here. Good. And then we're going to do thumb extension. All right, go into thumb extension for me. Good. And then ulnar deviation. Good. And then we'll come over here, we'll assess bilaterally. Finger flexion, good. Thumb extension, good. And then ulnar deviation, good. And that's C8. What we have for the lab practical is T1, your favorite, jazz hands, finger abduction and adduction. I had the mask on, so just to be more audible, the first test we're doing is adduction, ADD. You're gonna have your hand like this and don't really pull your fingers apart. So, good, oh my goodness, good. Good, good. And then we'll assess bilaterally. Don't pull them apart. Good, 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 good. And then now we're going to do. And then again, just for clarity, the next test is abduction, ABD. Have them out like this and don't only push them together. Good, 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 good. And then good, 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 good. And that would be T1.
And go.
So the first dermatome we have, which now that comes off of the dorsal side of the spinal cord like we talked about earlier. So the first one we have is T10, which is in line with the umbilicus. So what we're going to do is when we do dermatomes, we want to do light touch, deep touch, and pinprick. I'm going to have you close your eyes so you don't get any visual cues. And so same, same.
Yeah.
And then deep touch, same.
Yes.
And then pinprick, same.
Yes.
And then that's her belly button right there, so we're doing it in the right spot.
Go.
So the next one is T12, and because Sarah has these really high-waisted pants, we're going to do it over the pants, but we know that we would technically want to do it on the skin. So again, we're going to do our light touch, deep touch, pinprick. Close your eyes so you can't get any sensory or visual input. And then we're going to stroke, same. All right, deep touch, same, and then pinprick, same. And then that would be T12, and again, we would do it on the skin if she wasn't wearing these goddamn pants.
And go.
All right, so the next dermatome we have is C5, the deltoid patch. It's important to note with the upper extremity, we want to assess our true patches. So like I said, for C5, we're going to do the deltoid patch. I'm going to have you close your eyes, and we're going to do light touch, deep touch, same, and pinprick, same. And that would be C5.
And go.
The next dermatome we have is C6, so the true patch is that dorsal web space. It does extend a little bit into the lateral forearm, but again, we want to assess that true patch. So I'm going to have you close your eyes again for me. We're going to go, here, pick your hands up for me. All right, open, all right, here we go. We're going to go light touch, same, deep touch, same, and then pinprick, same. That's the dorsal web space on the dorsal side.
Go.
The next one is C7, which is the tip of the middle finger. So we're gonna find the middle finger. If you can't find it, just have them flip you off. But we're not gonna do that. So it's right here. So close your eyes, and then I'm gonna go light touch, deep touch, and then pinprick. Same. All right. And so she was able to feel all those.
Go.
So next we have C8, which is the ulnar border of digiti minimi. A little bit extends into that median forearm range, but we're just going to assess the true patch. So I'm going to have you, yep, there you go. And we're going to close your eyes, and then we're going to do light touch, deep touch, same, and then pinprick, same. And that would be C8, that digiti minimi area.
Go.
And the last one we have is T1, which is superior to the medial epicondyle on the medial arm. So here we go, we're going to do close your eyes, and we're going to do light touch, deep touch, and then pinprick. As you can see, the pinprick did work. Okay, so just like the last lab practical, we only have one reflex we're going to do, and this is the C7 reflex, which is the triceps reflex. So remember, a reflex just is assessing the integrity of a nerve root, and a reflex is a simple reflex. When you tap the tendon, the signal goes onto the spinal cord, and then it jumps onto an effector route, and then it will go and cause a contraction in the muscle involved. So like I said, we're doing the C7 reflex, and then as I actually perform it, we'll show the positioning of the arm, of the upper extremity, what side of the hammer we're going to tap with and all that. So I'll show that in like 3 seconds when I go into it.
Go.
So now we're going to be doing the reflex. The only one on the lab practical is C7, which is the triceps. So what we're going to do is we're going to have them hold their arm out with this nice 90-degree angle. You're going to stand behind them because we're looking for elbow extension, so we don't want to get obliterated by her arm. And then you want to use the flat side of the hammer because we only use the pointy side for brachioradialis that we've talked about thus far. So relax for me. Oh, my bad. And then I'm going to hit the triceps tendon, so right up here above the elbow. We're going to look for a little elbow extension. We got a little bit there. And then we want to assess bilaterally, of course, so same position. Relax for me. And then we're going to hit right above the elbow, looking for elbow extension as we got right there. And that's the C7 reflex. Next we have the ulnar head, so that's out on the ulnar side. So we have right here is ulnar head for her right arm, and then out here is ulnar head for her left arm. Then we can do the medial epicondyle where our flexors come off of, and that's right here in the medial arm area. Right back here is medial epicondyle for her right arm. And then can you get right in here? Right there where my thumb is would be her medial epicondyle for her left arm.
Go.
So now we're going to do the acromioclavicular joint. So the best way to find this is you want to find the spine of the scapula. You can walk over. Once you get that curve, you're on the acromion process. And then where the clavicle comes up and they meet, right there is the AC joint. Right in there. And then again on this side, if we were doing an assessment, we could walk our hand across. We get where that angle is, and then the clavicle comes up here, and the AC joint is right here. And then if we want to come around, while we're at it, we'll do the sternoclavicular. This is not a hard one. You have the jugular notch right in here, so sternoclavicular would be here for her right and here for her left. So now we're going to be palpating the greater tubercle of the humerus right in this area. And if we do internal or external rotation on functional, that's lesser. Oh, you can feel it pop right in. Lesser would be when we're in external. Internal, we get the greater tubercle, and if we pop down here, we're in that bicipital groove right there with the long head of the biceps tendon would be palpated. And then if we were doing an eval, here's that bilateral assessment. If she goes into that external, we have the lesser, and internal, oh, you can feel it. Again, we have the greater. If we drop down, we can get the long head of the biceps tendon. Here, and what we can do, we didn't do on the other side, we don't have to, but if we put resistance, it kind of pops out, right underneath your finger there. That's the long head of the biceps tendon. Now we're going to be assessing the radial head. So what we want to do is we want to find her lateral epicondyle. If you want to come over here. We're going to put our IP joint, and then our thumb should be, if we go 45 oblique on her radial head. If she goes into pronation and supination, oh, look at that. You can feel it spinning underneath the finger. Then we'll assess bilaterally for a comparison. Ooh. I feel cool with the chair. Find that lateral epicondyle, and then we're going to go put our IP joint, go 45 degrees, tip of thumb, yep, and you can feel the radial head spinning in pronation and supination. So now we're going to do the radial carpal joint. So that's between our carpals and our radius. And we find the radius, right in between where our carpals are and the radius, and right in there, yep, if she goes into extension, you can feel it gliding. That'd be the radial carpal joint. And then bilaterally, the radial carpal joint by the radius. Oh, yep, you can feel it. And then we are doing the distal radial ulnar while we're at it. So we can actually, if you go between the radius and the ulna, we can immobilize it. And then between radius and ulna. So now we're going to do the scaphoid and the second pip joint, or proximal interphalangeal joint. So we'll start with the scaphoid. So if you want to make your anatomical snuff box, look at that. And then right down in there is the scaphoid. And then make an anatomical snuff box. Right there's the scaphoid. And then we want to do the second PIP joint. So right here, you can only do flexion and extension. And then again, the second pip joint right here, flexion and extension. And that's again the proximal interphalangeal joint. All right, so now we're going to do the inferior angle of the scapula. So the easiest way to do it is have them put their hand behind their back. You'll get that winging. And right here we get the inferior angle. And then if we want to assess bilaterally, And right here we can get that inferior angle of the scapula.